Well, good day to everyone who's joining us live. My name is Paul Ashley. I'm a senior vice president and consultant with First Person, now proudly a subsidiary of NFP. Obviously, that news was just released here in May of this year, and we couldn't be more excited about our new partnership with NFP, or a growing partnership, better to say. Today, we have a very hot topic. We're talking about pharmacy benefits, the impact those have on both the bottom line and the health of your organization and the employees that you employ. It's been a topic fraught with a lot of challenges, and I'm kind of well known around our office for saying that if the average consumer knew how PBMs work, pharmacy benefit management companies worked, there might be fights in the streets. But we'll dig into that a little bit later, and you'll see. A couple of housekeeping items. First of all, you'll have the opportunity to download these slides. You'll see these come out as handouts, so you'll be able to download those. Nicole and our team will launch those behind the scenes, so make sure you click on that and get copies of this. Also, for those of you who are part of the Society of Human Resource Management, also known as SHRM, this hour-long session is approved for SHRM credits. So click download on that if you want to make sure you're getting your continuing education credits. And even if you're not a member of SHRM, sometimes that education credit thing can help with other professional organizations just as proof. So click on that to download if you'd like to. Well, today we have the distinct pleasure of being joined by two great folks. One local, Cam Troxel, who is our Vice President of Benefit Strategy here at First Person, and then Nellie Rose, who's the smartest person on this presentation. She is a PharmD, and she is the Vice President of Clinical Pharmacy at NFP RX Solutions. So now a co-worker of Cam and I. So Cam and Nellie, if you want to pop on here real quick and join, you'll see their beautiful faces. Here they go. There they are. Nellie is probably the farthest traveler. She came all the way from St. Louis, virtually from St. Louis. And Nellie, I didn't have a chance to confirm this, but are you in fact a Cardinals baseball fan?
Of course. Good. And Blues.
Okay. Blues. All right. This will work. This dog will hunt. So I'm glad to hear that's true. If at any point during the time you want to ask questions, you've obviously already seen the chat. Some folks have talked about where they're joining us from. So chat questions as we go. We will leave a little bit of time at the end to answer. And if they're really pertinent questions to create clarity, we will step in and sort of say, hey, time out, Cam, time out, Nellie. Can you clarify for this? And I'll keep an eye on that on behalf. So I'm going to turn it over to Nellie and let you take this. I'm sorry, one more housekeeping. There's another call to action here. It's like I should know what I'm doing. I should be a professional. There's a chance also for you to download the 2021 trends report. And these are national trends, U.S. benefits trends that have been compiled by the NFP team. And they're in all areas. It does include pharmacy as one of the trends. Actually, I think, Nellie, you're featured in here. So if you like Nellie and what she has to say, you can read more about what she has to say and other trends unrelated to pharmacy. So do download that. And this is now where I kick it over to myself again. It's like I should have planned this. So when we're talking about benefits in particular and what today's going to be about, we talk about pharmacy, and that clearly fits in that benefit slice. But I think when folks hear from us, you have to understand that as a firm, we look at this in a more holistic sense, right? And so in the center of this is the employee experience at your company. And on the outside of this, there are things that impact the employee experience. So there's how you design your organization, your leadership training, your development, things of that nature. On the bottom left, you can see there's external market factors. And I think we've lived through the last 18 months of some unplanned factors like the pandemic. But these different pies make up things that can impact the employee experience. And wrapped around the employee experience is how you communicate with employees. And we think that's a huge factor on whether they have a positive or negative experience. Well, today we're going to zoom in deeply into the benefits area and specifically pharmacy benefits landscape. And now I will correctly hand it over to Nellie and get out of her way. Nellie, take it from here.
First Person for having me here. I see a lot of data. I read a lot of industry insights, and really wanted to share with you guys what we're seeing from the biggest high-level perspective down to more granular of what each individual unique client may experience in the pharmacy landscape. So the next slide is going to kind of show you from the biggest aspect, the global medicine spend. So when you take a look at this forecast and trend, global medicine spend is expected to increase at a rate of 3 to 6% on average per year, and it's going to reach almost $2 trillion by 2025. So when you take a look at the forecast in the box, what does that mean? When we're seeing the driver of this increased spend, it's attributed by new branded products. Those new branded products are estimated to add $187 billion to pharmacy spend over the next 5 years. And these products are specialty medicines. Pharma's focus has shifted away from traditional therapies to more novel agents and even more curative therapies. So specialty medicines will account for nearly half of the global spend by 2025. And it's anticipated that it will reach closer to 60% of spend in the top 10 developed markets. What we're already seeing in the industry is that specialty medicines have already reached that 50% of the planned spend for pharmacy. Let's go to the next slide, and I'll share something else with you. So as we have seen this increase in healthcare spend, high-cost therapies, new novel agents, really blowing up our industry, our government has taken a lot of action in the last few years, excuse me, to tackle some of those high-cost claims and to try to lower some of those healthcare expenses. So, legislature from a federal perspective and state levels have really increased on their focus since we've kind of reshifted our focus away from COVID vaccines and all the COVID legislatures. We're now trying to recalibrate and refocus on kind of our bigger issue, and that's the healthcare spend.
Nellie, Nellie, quick question for you. If you were in charge of U.S. policy on pharmacy for a day, number one, things would be a lot better. It'd be amazing. Number two, what is one thing you would want us to do from a policy perspective across the nation to really harness in the challenges we have with RX costs?
Yeah, International Price Index. So in here, the best of nations. The biggest issue that we see in the US is that our costs for drugs are much more inflated than our neighboring countries. Canada, Europe, we're seeing 20 to 30% increase in inflation in our drugs than some of our neighbors. And the reason being is because of our private insurance, but also because of innovation. So pharma manufacturers are selling the same products at a much lower cost internationally, but here locally, we are the ones paying the price for their innovation. So some of these, legislative policies help mitigate that, but still a lot to uncover on what the, kind of the long-term goal will be like. So a few of these legislative policies I really wanted to focus on. The International Pricing Index, so it's called the Best of Nations. And what essentially it does is it caps Medicare Part B prescriptions that are infused in the doctor's offices, and levels out the pricing compared to the other 15 developed nations. So you would see these a lot of J-code drugs that are hyperinflated over AWP that have very little management when it comes to the medical side.
Just let me pause there, right? Because you're such a smart PharmD. You know what J-code means. You rip it off it comes off your tongue really easily. Just so for the folks listening, a J-code is essentially the insider terminology that's used when a prescription drug is filled through the medical plan, not through the pharmacy or the pharmacy benefit manager, but through the medical plan. And typically because it's being administered in an outpatient or sometimes inpatient environment and not at somebody's home, although that can happen as well. So it's essentially high cost drugs that are marked up significantly on top of their already existing high costs and administered through the health plan.
Yes, thank you. And in the, although it's a necessary need in many instances, there's a lot of loopholes that have happened in recent years to help physicians or outpatient facilities recoup some of their costs for those high cost injectable and infusible agents that can be available through pharmacy with a lot more strategies and cost containment. So that's one thing. The other, executive order really made some headlines is life-saving medications. So it actually started with the Trump administration and really continued through with Biden's administration to help access some life-saving medications such as insulin and EpiPen by requiring certain federally qualified health centers to pass through 340B discounts to their patients in order for them to receive those drugs at pennies on the dollar. And it's called penny pricing. It's kind of our terminology. Other states have taken additional initiatives outside of the federal government to impose state mandates, such as putting caps on out-of-pocket costs to protect patients at the point of sale at pharmacy, or putting caps on certain therapeutic classes like insulin costs, because that was a financial burden to a lot of patients, especially those on high deductible plans.
Uh, 20 months of the pandemic, I know to unmute. So quick poll question. You've got three choices. And we're going to give you the right answer. So this is a test. Which do you think is the primary driver of pharmacy costs? Is it inflation, the mix of drugs, or the intensity of drugs? And you're like, I have no idea what that means. Well, just guess. We can't track who gave the right or wrong answer. So don't feel nervous. Give it a few more seconds. Is it the inflation price of drugs, the mix of drugs, or the intensity of drugs that's driving the primary driver of pharmacy? By the way, all of them are driving, but what's the primary driver? All right. Looks like folks are leaning towards drug mix. Close second is inflation, then last is intensity. All right, not bad. We'll explain what it is here in a second. So, is this you, Nellie, or Cam? Are you taking over? This is Nellie. Okay, Nellie, what's driving it?
So, the primary driver is the drug mix. But as you can see in the drug trend, you can see the last 2 years of what has been the major component of trend by the mix, right? So when you think about a drug mix, the trend that we've seen is focused more on the expensive specialty medications. When you think of inflation, that is the cost of the medications that's set by drug manufacturers, although people like to blame PBMs for that. Really, the cost is determined by the actual pharma manufacturers and negotiated with PBMs. And then you have your utilization, which is how many members are being prescribed and actually using that medication. So when you look at trend, to understand ways to truly manage that, you have to understand what those three components mean. And so when you think about managing those components, you have to think about, okay, for pricing, we can't adjust pharma's prices, right? We can't adjust the inflation, but we can strive to get our clients to the lowest pricing through our contracts, preventing stale contracts with renewed market checks and annual price negotiations. So that's one way to tackle that. Then when you think about the utilization and the drug mix, well, those can be managed with clinical programs. They can be managed with formularies, with networks, and then utilization management rules to help guide patients to the appropriate clinically equivalent medication that's right for them.
Yeah, very good. So obviously we now know the drivers of increased cost on the pharmacy side of things. Really interesting here. When we look at the prevalence versus the cost of each specific drug category, and you may be thinking gene therapy or orphan drugs and things like that. What in the heck is that? We're going to talk about that here in a moment. They're fortunately not incredibly predominant at this current point in time, but they are two growing classes of drugs that Nellie will discuss again in a moment. But what's really interesting here is that the gene therapy drugs, the orphan drugs, and the specialty medications really only account for 1 to 2% of the overall utilization or the volume of drugs on a benefit plan. But you can see the costs on average for each one of those respective classes, gene therapy being $2.1 million, orphan drugs being $20,000, and specialty drugs being $5,000. And as those grow in prevalence and their costs continue to inflate, it creates this compounding effect on the overall cost on the health plan. And Nellie mentioned previously that the specialty medications account for roughly 50% of the overall spend in the pharmacy world. What's really interesting though is that that's a macroeconomic metric, and if we skinny that down on a case-by-case basis, if you're a health plan that has 500 or so employees, or even 200 or 300 employees, it's incredibly possible that you have one drug or two drugs that make up 50 to 90% of your overall medication expense. Sheerly because of the volume of cost on those drugs relative to the overall spend that you have, just because your unit is so much smaller in terms of total head count when we're comparing it, again, microeconomics versus macroeconomics. So from a trend perspective, we look at specialty drugs just specifically. This is quite eye-opening, but since 2008 through 2021, it's estimated that the 14-year trend is 384% in terms of the overall cost or the cost per specialty medication. Really, really alarming when you think about that in the context of other markets. And if you're just a general consumer and you have a product that you buy on a regular clip, let's say that we're talking about milk, there would be a heavy national debate, and it would be all over the media if milk grew in price by 384% over a 14-year period. We're kind of starting to see it a little bit with gas prices, right? Gas prices are creeping up, but I don't even believe they're over, double what they were within the last couple of years at this particular point in time. So, you've got a heavy economic trend here that is just so happens to be in this healthcare and medical world that doesn't have quite the same level of attention because it's not everyday consumers that are using these specialty medications just yet. So with regard to that, the top selling drugs in the US in 2021, first I would point out that 4 of these 10 are cancer treatments, and that's becoming more and more the norm. There are a proliferation of cancer treatment medications, and there are just a litany of them lined up to be approved through the FDA for use. And the cost, I'll tell you, is not going down, as you can imagine, for those respective medications. So that's going to be a continuously growing trend. The other medications, so the ones that are not boxed out in orange here, fall into a variety of categories. But what's interesting about those is that if any of you watch TV in the evening, in all likelihood, most of you will see advertisements for any one of these drugs, maybe multiple of these drugs. And so it's very, very common. Humira, I'm sure every one of us on this webinar has seen a commercial for Humira. It is the #1 drug in America and had a total sales of $20 billion. That's billion with a B in 2021. So I told you we would talk to you about what rare diseases, gene therapy, and orphan drugs are, and so I'm going to pass it. Paula aptly said that Nellie was the smartest one on this call. I'm going to pass it to her right now to tell you a little bit more about what these are.
Thank you. So, just to kind of level set why we're seeing this increased trend, why we're seeing low prevalence, high cost, and that's because the focus in biotech, in pharma, has really shifted to rare diseases and orphan drugs. So they're essentially treating novel conditions. A rare condition is actually defined as a condition that affects less than 200,000 people in the US. And orphan drugs are those novel agents used to treat rare conditions. So they actually go through a completely separate FDA approval process, through an accelerated process with more patent protection, cost guarantees, and tax incentives in order to develop and incentivize new drugs for these rare conditions. But if you go to the next slide, you'll see that rare conditions are not as uncommon as you believe. In fact, there are 7,000 identified rare diseases, but only 10% of them, 10%, have FDA-approved treatments, meaning that right now, that is a very heavily untapped market and growing. So as you see the stat, 1 in every 10 American has a rare disease. So even though it may impact a small population, there's a really good chance that 1 in 10 people will have some sort of a rare condition of those 7,000 that are still being researched and growing. So with that being said, understanding that this is, a market that has a lot of financial incentives for biotech and pharma, that has a lot of growth potential to really infiltrate our market, and the pipeline is filled with new and novel therapies. So we're seeing that shift in pharmacy. We've been seeing that shift the last 5 years. We're going to continue seeing that shift. And just to let you guys know, cancer therapy, in fact, is considered a rare condition. So when you think about cost of these conditions, the average pharmacy cost of an orphan drug is approximately $140,000 a year, okay? That's 20,000 times more than a traditional therapy. And typically, those orphan drugs come up in your top 10 indications, your top 10 spend in pharmacy, and it's typically driven by 1 or maybe 2 people. So when you think about, rare conditions such as cystic fibrosis, hemophilia, hereditary angioedema, and then enzyme deficiencies, those conditions can cost up to almost $450,000 in annual cost between medical and pharmacy to truly treat those rare conditions. And we're starting to see it becoming a more common trend.
What is the price range? You don't have to nail it. Of the most expensive FDA-approved medication on the market today? Is it less than 100,000? Well, if you just listen to the last slide, you know that's wrong. Is it between 100 and 199,000? Is it between 200 and half a million, or are we something north of $1 million or even $2 million? Yeah, with about 16 people answering. Technically, none of these answers are right. The most expensive drug is around approved and on the market today is around 2.1 million. So the folks who guessed half a million to 2 million will give you the Price is Right credit of being closest without going over. But there is a drug on the market right now that's about $2.1 million. Luckily, it's an outlier and it's pretty rare, but it's there, and it's a good indicator of the economic impact that it can have on a plan, as well as economic opportunity that biotech and pharma companies have to capture that market, as Nellie pointed out.
Yeah, so gene therapy, let's talk about it. To understand why these costs are so high for some of these curative therapies, we have to understand how they are being created and what they're intended to do as far as quality of life care. So gene therapies are actually targeted therapies that are root cause. So when you think about that $2 million medication, it's actually fixing the root cause at the DNA level to identify that genetic defect. Maybe it's adding a certain molecule to the DNA, maybe removing a defect, maybe adjusting it, but it should be a one-time treatment to help cure a hereditary underlying disease that helps span the quality of life for many more years, rather than constantly treating the symptoms of a disease and having that recurring cost year over year, having more of a targeted one-time therapy. So to give you a little perspective of how popular gene therapies have become in the marketplace, the global market for gene therapy is expected to reach almost $17.5 billion by 2023. The FDA expects 200 new gene therapy applications in the next 2 years, and it's predicted that we will have anywhere from 10 to 20 gene therapies that will be on the market by 2025. So with that being said, let's look at some of the gene therapies that are on the market right now.
Just to get to the point of it's a curative drug.
Mm-hmm.
Are you telling me that Luxturna, for the right patient, will reverse inherited retinal disease that causes blindness? And so you get into this debate of, well, if it's my child, then it's worth every penny of $850,000, right? When it's close to home. But then you look at it across a macroeconomic impact, and it's like, how do you deal with that?
There's a big but with that. Unfortunately, it's hard to claim that something is going to be a cure-all and you're never going to need anything for that ever again, because we don't know the long-term effects of these gene therapies. They're so new, right? So when the price is being negotiated to bring these drugs to market, it takes that macroeconomic cost into consideration when you think about medical costs, pharmacy costs, administration costs, ER costs, everything that can come together over a lifespan. And then how do we put a one-time sticker price on it to help mitigate that cost? The big question in the industry is, well, what if it doesn't truly cure? Or what if it only cures it or alleviates the condition for a certain time and then has a weaning effect? Those are the questions that are really kind of the basis of what we're seeing in the industry is, well, prove it. Then the other thing is, well, if we're spending $2 million on our population and we have a high attrition rate, where's the security in that? So it's having management strategies in which you are helping improve the quality of your employees' health benefits without just giving away money. So one thing I did want to mention is one quick strategy that we have been recommending for gene therapies is payment plans. So pharma manufacturers actually have this value-based payment option in which you can have, like a 5-year payment plan to help cover you and your employees in ensuring that there is some sort of risk that is being shared with the pharma manufacturer, that if within that 5 years there is no quality of life improvement, that there's reimbursement guarantees associated with it. So having those strategies in place really helps alleviate some of that sticker shock.
Very good. Really appreciate the understanding there on gene therapies and this emerging set of drugs. Certainly, it raises a lot of alarms from a cost perspective for many health plans. So now we're at the point of, all right, we've told you the nature of the situation, what's on the horizon, but so what? What do we do about it? What are the solutions that we might want to consider to deploy? help more effectively manage the spend on our respective health plan. So generally speaking, pharmacy benefit managers, or PBMs, fall into one of four buckets. There are carved-in solutions, there are coalition/consortium type solutions, there are transparent PBMs or independent PBMs, and then there are fiduciary PBMs. So talking a little bit about each one of these. Carved-in solutions are more your standard PBM arrangements where the large carriers have their own PBM, and it's a part of their entire service offering. And you essentially have an off-the-shelf formulary. There is some degree of flexibility in terms of some of the particulars that you might decide to choose about having a broad formulary or a more restrictive formulary. There is a pretty high degree of administrative efficiency. If there are, if that solution is already part of your medical program, it's already baked in, the lines of connectivity are already established, and things like that. It drives a good administrative cost, so you have low administrative fees. And from a clinical programming perspective, there are emerging programs that these solutions are beginning to deploy to help drive down cost. Yeah, so one really good example is Anthem with Ingenio. You've got United Healthcare with Optum, so on and so forth. Then, so the second type would be, so the remaining three are what we would call carved out solutions, or you're carving them out of the arrangement with your medical provider, your health plan carrier. The coalition or consortium, basically this is a contractual consortium, if you will. So you leverage the belly weight of several million members, and you approach through the consortium a CVS, a Caremark, a large PBM, and you drive a much better fee arrangement than is available direct to that respective PBM.
And RX Solutions does a ton of things. One of them happens to be running a coalition consortium that has approaching almost 2 million lives in it. And as you can think, if I'm a 500 life employer and I go direct to a PBM, I get a much different contract and much different pricing model than if I'm a 500 employer inside a 2 million life coalition or consortium, right? And so that's the idea of a consortium.
Yep, absolutely, Paul. Then, so the last two are what we call transparent or an independent PBM. These are PBMs that is their sole existence. They've identified an opportunity in the market. Generally speaking, the PBMs that fall in this category are paid an administrative fee for the services that they provide. It's usually a per script fee that you pay to those folks, but then any and all other sources of revenue, as it relates to the plan itself and the drug mix and things like that, those are all passed directly back through to the employer. So it's kind of a base administrative fee, and then in some situations there might be some shared savings elements that would be paid to these folks for managing specialty medication expense effectively and things of that nature. And then on the furthest right-hand side, there are fiduciary PBMs. That's exactly what it sounds like. These are fairly few and far between, where you get a PBM that will contractually bind themselves to being considered a fiduciary of your specific pharmacy benefit plan. So similar to the transparent side, just taking it one step a little bit further and naming themselves as a fiduciary with regard to managing your plan. It's not always the case. From a unit cost perspective, there are certainly a lot of variables to consider. Sometimes you can get a little bit better price on a per drug basis in one of the other arrangements. So it's really a function of comparing all of them, providing a shared and the exact same set of data to each one of those respective parties, and allowing them to weigh in on that data and telling and informing what what financial outcome they would have with that exact same set of data. We're at First Person, we're agnostic on that. We find where some of these solutions are really good, and it's really a case by case basis.
Cam and I and Nellie and a bunch of people wrote it, but they have to have one author. So somehow I got credit. I don't know how, but take a look at that. That was the work of a lot of people coming together to talk about kind of what you know and what you don't know about PBMs, and it really just recapped a lot of what Cam just said in that prior slide.
Yeah. So now I'm going to pass it back over to Nellie to talk about some of the management strategies that
and just to kind of recap, when you look at all those different PBM arrangements, what you really have to ask yourself is, well, what kind of tools do they have in their toolbox to really help my population manage the most effectively, both from a cost perspective, from a clinical perspective, helping ensure that there's minimal disruption, patient education and adherence, and really giving you that rich benefit and avoiding unnecessary costs. So those are all things that as consultants we take into consideration, because there's definitely benefits, pros and cons with each arrangement, and it's really just understanding how can you as an employer take advantage of those tools that are possibly right for you. So looking at what are your trend drivers, looking at, well, what kind of population do you have? Are you an IT group? Are you in labor and unions? Do you have a lot of consumer-driven plans? Young, old population. A lot of things that you have to take into consideration than to just having a one off-the-shelf solution. And those are options that are available to you that we at RX Solutions, bring to surface. So one of the strategies, and I'm going to kind of dig into a little bit high level on some of the strategies that we look for in order to truly help maximize opportunities. Formulary management. And I'll tell you this, time over time, I hear all the time, well, I don't want disruption. I want an open formulary. I want easy accessibility. I don't want to have to worry about anyone having an exclusion on the medication. And then when formularies update, when PBMs update their formularies, sometimes quarterly, sometimes semi-annually, sometimes it becomes a bigger chatter than it needs to be. And so I wanted to bring this light to your attention, because as you can see, year over year, more and more drug exclusions across the industry, across all the PBMs have been happening. And when you read articles, media, all the anti-PBM hypes, they're trying to say that PBMs are taking away these therapies from patients. When in reality, that's that many more drugs that have come into the market, whether it's new therapy or new generics, more competition in a certain therapeutic state, that now can replace some of those old strategies, new engagement, new opportunities, and sometimes mostly lower cost clinical effectiveness. So understanding that, formularies need to be reshifted, reevaluated as the market progresses is actually a healthy strategy in order to truly help lower healthcare costs. Because at the end of the day, you don't want the government having that control over how we manage our spend. We want to have that control that's right for us. So another very popular strategy is having a multi-tiered formulary design. So I will tell you, at this point in time, if on your pharmacy benefit, you are still having a 3-tier formulary, you are outdated, okay? That is no longer a relevant strategy in the marketplace. And the reason being is because no two drugs in these categories should be treated as if they're all traditional. So in a 3-tier formulary design, you have your generic, you have your non-preferred, you have your preferred and non-preferred, and those are typically in a traditional bucket. Well, with the increase in trend in specialty pharmacy, it really should be bucketed in its own category so it can be managed appropriately. So that's called the fourth tier. So within the fourth tier now, you've added specialty, you carved out specialty into its own tier, and now you can help drive consumerism within that bucket to the lowest cost alternatives that are available in specialty. So you can even break down that fourth tier into 3 individual components, driving to generic specialty, preferred, and non-preferred. As more competition enters our marketplace in that specialty category, you're going to need to have to drive a direction to help drive consumerism and lowest net cost. So although specialty, as it stands right now, is still primarily brand utilization, I think it's about 95% brand right now as it stands. By having those 3 tiers implemented early on, helps actually drive and promote consumerism as generics come into the marketplace without having to readjust your plan design every year or two as the market changes. So that's a proactive approach. The next approach is clinical management. And I guarantee you guys have all heard one way or another of utilization management, prior authorization, step therapy, quantity limits. But very seldomly do people truly understand what the purpose of those components of utilization management are. So when you think about prior authorization, it's ensuring that it's the right drug for the right indication that's FDA approved, written by the right prescriber that follows clinical guidelines. You cannot assume, and I've been in this industry for a long time, I've really seen it all. I've seen the craziest things happen. And many a times it's because there's assumption, well, why would a doctor write for a Humira for an off-label indication? Don't they know better? Well, we can't make those assumptions. We need to ensure that it's clinically appropriate and it protects our membership. Step therapy encourages that lower cost clinical alternative to be tried first before going to that high cost drug. So, a good example of that is you have a child that turns 16 years old. Are you going to buy your child a brand new Jaguar for their first car? Or will you start them maybe on a Ford or a Kia, right? Because chances are they're going to ruin that first car. So when you have somebody that's naive to therapy, that's starting a new medication, you really want to drive them to those lowest cost alternatives for that indication before going to that grand slam high cost product. Because in many cases, those lower cost alternatives are sufficient therapies to help them get adjusted to it. And then having, quantity limits that I consider quantity limits could be life-saving. And in many ways, because it prevents overuse of medications, overutilization, overfills, when there are, therapeutic thresholds that have to be reached and sometimes are being dismissed. So when you combine all those components together, that's what you consider to be clinical management. And then on top of that, you have some kind of unique out-of-the-box solutions. So when you start to see specialty costs really increasing in spend, and you're thinking, okay, well, we have put all those strategies together. We have good formulary management. We have, that utilization management. Well, we're still seeing that trend. What next? So across the industry, we've seen, and here at RX Solutions, we even have our own program that helps cover some of those high-cost specialty medications, whether it's through alternative procurement, through patient assistance programs, or through copay assistance that's available through the manufacturer. And what it does, it offsets some of those high-cost drugs and shifts it back to the pharma manufacturers because they offer thousands upon thousands of dollars in copay assistance to help cover the cost of that medication. And many times it's not being fully tapped into knowing how much money is available for these specialty drugs. So finding those unique solutions
can be a little complicated for the untrained eye, but essentially
encourage.
What you're saying here is when you do these copay cards, they're great. They save the plan money and they certainly save the member money, but be careful. You need to put what's called an accumulator adjustment in there so that they're only getting credit towards the deductible and max out of pocket for what's actually coming out of the consumer's pocket. Is that essentially what this visual down here says?
Yes, and that's another component of it, correct. Because what has happened historically that's also driven the cost is people on high deductible plans that are on specialty therapy would take a copay card. That copay card would cover their entire deductible, and that member only paid maybe a $5 copay to cover their entire deductible in one fill. So some of those programs hold the integrity of a plan design in place and ensure that an HSA qualified plan stays
all right,
compliant with the IRS
and next
first
to
dollar
last audience
coverage.
participation portion, you'll have one at the very end too. Which of the following would be your next step to contain pharmacy costs? So you have to choose one of the following, right? You might say, well, I don't want to do any of them. Well, you got to choose one that sounds the best. We've got carve out the pharmacy. Cam talked about the different carve out models. Implement specialty RX clinical program to really drive down the highest cost meds. Exclude specialty. In other words, just say, listen, we're not even going to cover it. And by the way, there's more that comes with that, as you can imagine. Medication therapy management, just having a good clinical resource, somebody like Nellie talking to your folks about the drugs they're on, or implement mandatory generics. So far, we got 6 answers. I'm going to need it. There we go. Okay, good. Which of these are you going to do? Looks like the leader so far, with about half of the audience answering, is I'm going to implement some clinical program around specialty RX to drive them to the most effective, most reasonably priced specialty drugs. Which, Nellie, how does that stack up? Given these choices, and there's other choices, right? In your opinion, how does that stack up? Are you surprised that's what people are saying?
She is the driving force
Cam,
of
you
the
got a success
pharmacy
story to
benefit.
share, right? Okay, great.
I get to brag first.
I do, but Nellie's is first.
I have thousands of stories to share with you, but I picked this one specifically because it was a client that was carved in with Cigna, about 500 lives. It's actually a pretty well-known organization and in the healthcare industry. So they were very health conscious about disruption, ensuring that their patients and their members were minimal disruption, easy access, and transparency and understanding where the benefit lies and what their options could be. So they needed some flexibility in their benefit. They needed to know what their options were. We carved them out with CVS. We created a member portal. We had some flexible plan designs. We really thought outside the box on, well, you know what, how do we, diabetes was really their primary focus to ensure that there was no disruption, there was no barriers in accessibility and cost. So we implemented a diabetic management program that essentially incentivized members to fill their medication, increased adherence, improved adherence actually by almost 4%. And we implemented some of our own clinical programs in addition to what we see in the contract. So the contract, that's the foot in the door. That's the easy button, right? It's the management and the ongoing trend mitigation that really keeps us and our clients controlled and happy. So this particular client, after the first year of carving out with us, saved 35% for their total pharmacy benefit. That's a huge negative trend. And what I want to say is, on average, now 35%, that's not a guarantee. But what I can tell you is, on average, we're seeing anywhere from 25 to 30% as what we anticipate the average savings are when you carve out. You have the improved contracts and rebates. You have a pharmacist that is helping manage your plan spend and has that ongoing communication and touch points with you, and really just understanding with the data that you may or may not have even seen in your current arrangement. We bring that all to light. That helps really manage things proactively rather than reactively.
What are you doing, bro?
So let me just say, I'll set the scene and I'll tell you some of the nuanced differences here. This is a 300 employee North American equipment provider. Came to us as a new client. It's first person. Had a high propensity of specialty medication expense, really driven by just one member specifically. The member had a condition of cystic fibrosis. We identified that it was, certainly an issue. They wanted to enhance their benefits for employees and look for cost savings opportunities. The strategy we implemented is because we went with a independent PBM. We turned on our Careline solution to support employees through that transition, to have employee questions answered and fielded through our Careline solution. We identified and implemented the new transparent PBM, and then we implemented a pretty aggressive specialty management program. On the Careline, almost 80% of the calls were resolved the same day. Great finding there. But we had $500,000 of savings just on the specialty management side, primarily, again, anchored by that one individual who had $375,000 worth of medication expenses for the year. What that boils down to is $1,548 per employee per year in savings, and 9% of their total spend. So just that one solution, just
Incredible
focused on the
stories, and those were
specialty,
just,
solved a
two
lot of
examples.
those
I mean,
problems.
Nelly could probably go on
And then
and
we
on.
had,
Tim, I know within our practice,
more significant savings
that's
with
just one
regard
story,
to
right?
just
The
overall
multifaceted approach
pharmacy
there.
performance as well.
Again, a reminder if you click on handouts, kind of over next to the chat, there's a couple things you can download. You can download the slides we've shared. You can download your SHRM credits, and you can, again, download the trend report. Nelly is featured in there, as well as 5 or 6 other national leaders. Really, today's session is a third in a series of sessions we've done with both some of our local experts like Cam and some of our national partners like Nelly, just kind of bringing national and local resources together. The idea that we're stronger together with NFP. We're excited about what that means here. As we wrap up, certainly, if you have any questions, I know, don't be intimidated. You're like, well, Nelly's a pharmacist. She's got a PhD in pharmacy. I don't want to embarrass myself. Well, go ahead and ask questions. By all means, we're willing to take those. Before you leave, we'd also love to hear your response of how likely are you to recommend a Resolve Increments session to a friend or colleague? It may not be this topic, but another topic. Just this format. Is it a 1, I'm least likely, or 5, most likely, or in between? It really helps us to know if we're hitting the mark with the content we're providing. So certainly let us know. So I'll just pause a few minutes and allow people to fire off questions in the chat. You may not have any, but certainly want that. And if you're a little embarrassed and you're like, well, I don't want to chat a question because I might say the wrong drug name, you can always continue the conversation by getting a hold of your advisor that you work with at First Person, and they can route that to a subject matter expert like Cam or Nelly, and certainly we can answer questions that way. Well, as we wrap up here in the last 3 or 4 minutes, when we close down, you're going to be redirected to another page. It allows you to sign up for our weekly boost articles that come out. It helps you with your people strategies. Nelly, any last minute thoughts you want to share with the group?
The pharmacy benefit's really complicated and convoluted, but if you have any trend or any trend drivers in your pharmacy benefit that you just need to bump against us, see what are my individual solutions.
Even if you don't want to use the consortium,
happy to help.
We have access to folks like Nelly at the RX Solutions team to be great consultants to us. Cam, any parting words on your part? Well, thanks to all who attended live and those who.
No, I would just echo the
in
same
the
sentiments
future.
that you and Nelly have already shared, that we're here to help
Make it a great
any
week.
way we can, and would love to have a conversation about it.